Guys, so we're going to talk real quick about the pharmacology of neuromuscular blockers. We've been talking about anticholinergics, right? And these block cholinergic receptors, but they're very specific for the nicotinic receptors at the neuromuscular junction. So they're not blocking nicotinic receptors at the autonomic ganglia. They're not blocking muscarinic receptors of the parasympathetic nervous system. They're just blocking the nicotinic receptors that are on skeletal muscle. Hence the fact that they're neuromuscular blockers. They're blocking stimulation of the muscle fiber at the neuromuscular junction. Right? So essentially they're preventing muscle contraction, facilitating the relaxation of muscles. There are two types of neuromuscular blockers. They all end up blocking the neuromuscular junction and causing relaxation of muscles. But there are agents that technically are classified as antagonists and agonists. The antagonists are non-depolarizing agents. They bind to the receptor, they don't cause depolarization, they simply block it. And then there are depolarizing agents. These agents bind to the receptor. They initially cause stimulation, and then they remain blocking it. So they are agonists. So they do cause depolarization, but then they just stay there and block the receptor. So ultimately, the result is that the receptor is blocked long-term. The uses of neuromuscular blockers, we use these in situations where the patient is going to be unconscious, for example, like during surgery, and we need complete relaxation of the muscles. We use this when we're intubating patients, so when we're intubating them for surgery, or when we have to rapidly intubate a patient. So for rapid sequence intubation, like in the emergency room, for example, or in an ambulance, for example, and the patient doesn't have an airway and they need to be intubated, we use neuromuscular blockers to facilitate intubation. When we use them in surgery, they're effective for intubation, and they also provide complete muscle relaxation, and they allow for us to use a lower anesthetic dose. So that improves safety of anesthesia, and it allows for a more rapid recovery from anesthesia. But note, these do not replace anesthesia. Okay, they do not replace anesthesia. Okay, so they lower the dose of anesthesia that you need, but you still need anesthesia. If you just give somebody a neuromuscular blocker, they're still going to be awake, they're still going to feel pain, they just won't be able to move. And that is the most nightmarish experience ever. To not be able to tell somebody that you can feel them cutting you open is terrible. Okay, so a neuromuscular blocker needs to be combined with anesthesia during surgery. We also use neuromuscular blockers to facilitate intubation and mechanical ventilation of critically ill patients. So critically ill patients, surgery patients, and emergency patients. So first we'll talk about the non-depolarizing agents. Curare was the first known of these agents. This is used by Amazon hunters, right? Like the darts, right, that paralyze the prey. It's a natural substance that is a neuromuscular blocker. We have multiple clinically useful neuromuscular blockers that are non-depolarizing. They are listed down here. Rocuronium is really commonly used. Rocuronium is the drug of choice for most emergency physicians for emergency intubation. Both rocuronium And then also we'll talk about succinylcholine as well. And the reason that both of those are useful in emergencies is because they have a really fast onset. But I'm getting ahead of myself. So non-depolarizing agents, they work differently at low doses versus high doses. At low doses, they bind to the nicotinic receptors and they block acetylcholine from binding. So they bind to the actual binding site that acetylcholine would bind to, and they prevent it from binding. These can be reversed by acetylcholinesterase inhibitors. In the last lecture, we talked about some acetylcholinesterase inhibitors, right? Like neostigmine, for example. Neostigmine is a peripherally active acetylcholinesterase inhibitor. We would not want to give physostigmine because that's centrally active as well. And these aren't working in the central nervous system. So we don't want to inhibit acetylcholinesterase in the central nervous system. We only want a ACHE inhibitor that's peripherally active. So for example, like neostigmine, edrophonium is peripherally active. So if you have a patient who you've given one of these agents to at a low dose, and you now want to reverse the neuromuscular blockade, you can give neostigmine to do that, and then the patient will be responsive. They'll be able to, respond to you if you need to do a neuro exam or something like that. Also, there's a drug called Sugamidex. Sugamidex is clinically used to reverse to reverse rocuronium. Okay, again, we'll talk in a second about like half-lives and why we might need to reverse it, etc. Also, and the reason that these can be reversed by acetylcholinesterase inhibitors is that you're blocking the binding site for acetylcholine. If you give an acetylcholinesterase inhibitor, you're going to increase the amount of acetylcholine that's present in the gap, and it can overcome the blockade of the neuromuscular blocker. Also, these patients can be stimulated with direct electrical stimulation. So direct electrical stimulation opens the ion channels directly. It doesn't require the binding of acetylcholine. So this opens ion channels directly, the cations flow in, the muscle contracts. However, when these agents are given at high doses, it blocks the actual ion channel. Okay, so that's different. When you block the actual ion channel, you can't reverse this by giving an acetylcholinesterase inhibitor, because you could have all the acetylcholine in the world. It could, overcome the blockade at the receptor and bind, but the ion channel is blocked. So no ions are going to flow in, the muscle is not going to be depolarized. Also, they're not going to be able to be stimulated by direct electrical stimulation, because again, that directly opens the ion channels, but they're blocked. So you can't stimulate the muscle with a direct electrical stimulation. We use direct electrical stimulation to monitor the level of neuromuscular blockade. So you can use direct electrical stimulation and see if the muscle responds, then you know you're at a lighter blockade. If it doesn't, then you know you're at full blockade. Muscle paralysis does not occur in all muscles at the same time. It occurs in the order that you see here, typically the face and eye first, and then you work from like the end of the limbs up. So like fingers and toes, and then arms, legs, neck, and then the trunk, and lastly, the intercostals and the diaphragm. And then when this wears off, recovery is in the opposite order. So the patient would gain use of the diaphragm and intercostals, the muscles that are used for breathing first, then the trunk, and neck, the limbs, right? Fingers, toes, face, and eyes. Kinetics, these agents are typically given via IV administration. Sometimes they can be given IM, so it's possible to administer them intramuscularly, but they're typically given via IV administration. The time to maximum blockade varies between agents. It's typically between 1 and 3 minutes. The fastest agents, again, are rocuronium, and then also a drug called succinylcholine, which succinylcholine we haven't talked about yet because that's actually a depolarizing agent. We'll talk about it in just 1 second. But those two are the fastest acting, even less than a minute sometimes. So if you are going to do rapid sequence intubation in an emergency situation where you need an airway immediately, then rocuronium or succinylcholine will get you there the fastest. The agents are big and charged, so they don't cross the blood-brain barrier. They don't get into the central nervous system. The duration of action is anywhere between 8 minutes and 90 minutes, depending on the agent. The rocuronium that I mentioned has a half-life of typically about like an hour. Rocuronium, has a duration of action of about 60 minutes. The succinylcholine is like 10 to 15 minutes. Right, so they both act really quickly, but the rocuronium lasts for a bit longer. The duration of action, again, varies greatly. Whatever one you're going to use depends on what you're doing. When you need it to work, how long you want it to work, and then also how it's cleared. For example, in patients who are critically ill, you frequently have multi-system organ failure, right? So if the liver's not working well, the kidneys aren't working well, that's going to impact what drugs you can give the patient. Cisatracurium is used in multi-system organ failure because the drug spontaneously degrades in the plasma. So it's okay if the liver's not working. It's okay if the kidney's not working. It's not going to build up. So it's useful in mechanical ventilation of critically ill patients. Cisatracurium also happens to have a long half-life of about 90 minutes. So that's helpful because it doesn't have to be dosed as frequently. Adverse drug effects are uncommon. It doesn't enter cells. It doesn't cross the blood-brain barrier. It's pretty specific in what it does and where it does it. Pancuronium can be vagolytic, so like anti-vagus nerve, right? Lytic is like opposite, so it stops or inhibits some of the vagolytic responses. So because of that, it can be associated with an increase in heart rate, but they are relatively well tolerated. The other agent we'll talk about, succinylcholine, is not as well tolerated. Drug interactions that can occur, acetylcholinesterase inhibitors, like again, we said neostigmine. Also other drugs like pyridostigmine, physostigmine, edrophonium, they all can overcome low doses of neuromuscular blockers. Some anesthetics sensitize the neuromuscular junction, so they can increase the effects of the neuromuscular blocker. Desflurane, for example, is one of these, so you don't use as high of a dose of the neuromuscular blocker. Aminoglycoside antibiotics, examples of these are drugs like, that's an E, gentamicin, or tobramycin. These inhibit acetylcholine release, so they increase the effects of neuromuscular blockers because you're inhibiting the release and you're blocking the receptors. So there's increased effects. So again, you might not need as high of a dose of the neuromuscular blocking agent. So those were the non-depolarizing agents, cisatracurium, rocuronium, etc. The depolarizing neuromuscular blocker is succinylcholine. Okay, succinylcholine binds to nicotinic receptors and it acts like acetylcholine, right? So it does not just bind and block the receptor. It binds the receptor and it stimulates it. So it causes depolarization of the muscle. So you do stimulate muscle contraction. However, it's not broken down by acetylcholine, so it stays. It binds, depolarizes the cell, and then just sits there. And because it stays there, it blocks any further stimulation. So you do see an initial what we call fasciculations of the muscle, or like twitch of the muscle. So right after you give it, you'll see like little flickering, little like contractions in the muscle. And then it stops and the muscles are completely at rest. The membrane does repolarize. The membrane does repolarize, but it can't be stimulated again because the drug is there blocking the receptor. So it results in flaccid paralysis, as in completely relaxed paralysis. Succinylcholine. Succinylcholine again is very frequently used for rapid sequence intubation. And again, the reason for that is that it has a really rapid onset. Like rocuronium, right? They both work really quickly. So they're both useful for rapid intubation. Also has an indication for electroconvulsive shock treatment. It's given IV, just like the other agents. The respiratory muscles are paralyzed last, just like with the other agents. The key difference here is that it causes the fasciculations first, and there are adverse drug effects that come along with that, which we'll talk about in a second. It's metabolized by plasma enzymes, has a relatively short duration. So again, the duration of action is between like 10 and 15 minutes. That makes it very desirable. For example, if you have an emergency room patient and you need to intubate them quickly, you need something with a rapid onset, like succinylcholine or rocuronium. But perhaps you need to do a neuro exam on that patient. So of course you can't wait until after the neuro exam to get them breathing. You need to maintain the airway immediately. So you want to, have a neuromuscular blocker that is that's got a short duration so that the patient's able to respond to you while you do a neuro exam. So it seems like, well, this has a short duration, this would be the best one to give. Sometimes the side effects of succinylcholine limit its use though. So there are situations where you would use the rocuronium instead. And then if you need to, in order to do a neuro exam, you could reverse the effects of it if you can't wait for it to go away on its own. So adverse drug effects of succinylcholine. Muscle soreness, and that's just because of the initial fasciculations. You've got, your muscles contracting all over the place, and sometimes they're sore afterwards. It can be associated with malignant hyperthermia. Malignant hyperthermia is rare, but it's possibly fatal. So it's a rare, possibly fatal increase in temperature. Now, certain patients are at an increased risk of developing malignant hyperthermia. For example, patients with increased potassium, patients with muscular dystrophy, are all at an increased likelihood of developing malignant hyperthermia. If you're giving this to a patient, if you're worried about malignant hyperthermia, you should have a drug called dantrolene on hand. Dantrolene is used to treat malignant hyperthermia. So if you have dantrolene on hand, at least you can give that to treat the malignant hyperthermia if it develops. Another big issue is that succinylcholine causes hyperkalemia. The reason for this is that, in the muscle contraction during the repolarization phase, potassium is dumped from the cell. So if you figure all of your muscles contracting all over the place, you dump a ton of potassium from the cells. So it is associated with hyperkalemia. It increases potassium by about 0.5, not zero, by 0.5 milliequivalents. If your potassium is fine, if it's not high at all, that's okay. But if your potassium is already high, that is very dangerous. Again, the high potassium puts you at a risk for malignant hyperthermia, but high potassium itself is very dangerous. It's got cardiovascular issues that it can cause that are very, very problematic. So you've got to watch out for hyperkalemia. Don't give it to patients who have hyperkalemia already or to patients who are at risk for hyperkalemia. So that's why we have these contraindications here at the bottom. A lot of those are related to the hyperkalemia. Also can cause apnea or worsen apneas. So avoid in burns or massive tissue trauma like crushing injuries. And the reason for that is that both of these massive tissue trauma, burns cause cell damage, and the cell damage causes a bunch of potassium to leave the cell. Remember when we talk about ions, most ions are more concentrated in the extracellular fluid, but where's there more potassium? Inside the cell. So when you have massive tissue damage, cells die, right? Cells burst, and all that potassium then gets dumped out of the cell. So there's a huge influx of potassium in the tissues. So both of those are already going to be associated with increased potassium. And then when you add succinylcholine, you dump another 0.5 milliequivalents, and all of a sudden you're at a dangerous level. In renal failure, patients with renal failure can't handle this electrolyte disturbance, and they're more likely to have hyperkalemia and then have, a problem result. And then again, electrolyte imbalances for the same reason.